Ya, setelah video tadi, maka saya akan memperkenalkan pembicara pertama kita pada pagi hari ini adalah Dr. Fathia Isbania, spesialis paru konsultan. Dr. Fathia menyelesaikan studi S1 di FKUI pada tahun 2000, kemudian beliau menyelesaikan program spesialis pulmonologi di FKUI pada tahun 2007 dan melanjutkan pendidikan magister edukasi di FKUI. Saat ini Dr. Fathia bekerja di Rumah Sakit Persahabatan sebagai Kepala Divisi Infeksi Departemen Pulmonologi dan Kesehatan Respirasi. Kepada Dr. Fathia, saya persilahkan.
Dokter, suaranya mohon di-unmute. Belum, Dok.
Dr. Hedi, saya sudah gabung kembali. Apakah mendengar suara saya?
Silakan, Dr. Fathia.
Iya, iya. Mas, kedengaran suara saya?
Kedengaran, Dok?
Oke. Ya, terima kasih. Maaf, tadi ada trouble. Cookies-nya keluar, nggak tahu artinya apa. Saya akan share screen saya ya. Apakah terlihat?
Terlihat, Dok?
Iya, Dr. Hedi terlihat?
Ya, terlihat. Ya,
Oke.
terlihat.
Ya, terima kasih Dr. Hedi selaku moderator dan terima kasih teman-teman semua sudah menghadiri acara pagi ini. Saya lihat pesertanya saat ini sekitar 65 orang peserta. Dan terima kasih kepada PTMSD yang sudah support PDPI untuk meningkatkan pengetahuan mengenai bacterial pneumonia ini. Seperti kita ketahui bersama, sudah 7 bulan belakangan ini kita sebagai dokter paru disibukkan dengan COVID. Tapi yang tak kalah penting, COVID ini selain dia menyerangnya ke paru-paru, selain virusnya yang bercokol, ternyata ada pasca ikutannya, yaitu bacterial pneumonia. Ya, pneumonia adalah penyakit paru-paru acute respiratory illness sebagai infeksi dan inflamasi pada parenkim paru. Paling sering adalah penyebabnya adalah bakteri, tetapi virus, jamur dan parasit juga dapat menyebabkan pneumonia. Seperti saat ini virus SARS-CoV-2 merupakan virus pandemi yang menyebabkan infeksi di paru-paru. Yang kita tekankan pada pertemuan pagi ini adalah bacterial pneumonia yang di setting hospital. Memang kita sangat jarang menemukan pasien pneumonia yang walk-in, yang rawat jalan. Sebagian besar adalah pasien-pasien yang dirawat di rumah sakit. Oleh sebab itu, kalau kita merawat pasien di rumah sakit dengan pneumonia, ya pasti dalam keadaan dia moderate severe, dan challenge-nya adalah tata manajemennya, tata laksana mulai dari diagnosis dan pengobatan. Ini adalah 3 definisi yang kita harus pahami, dan ini mungkin teman-teman sudah pasti tahu semua. CAP, HAP, dan VAP. Kita sudah tidak lagi menggunakan HCAP karena itu hanya sebentar saja kita menggunakan HCAP, hanya sekitar 2-3 tahunan, karena ternyata kumannya hampir sama dengan HAP. Yang pertama adalah CAP, adalah pneumonia yang didapat di komunitas yang etiologinya bukan dari rumah sakit, atau community acquired pneumonia bacterial, CAPB. Ya, jadinya ada istilah baru, semuanya ditambahkan bakterialnya. Sedangkan kalau hospital acquired pneumonia atau HAP adalah penyakit infeksi pada paru, pneumonia, yang disebabkan oleh mikroorganisme patogen dan dapat terjadi pada pasien yang masuk ke rumah sakit lebih dari 48 jam atau dalam masa inkubasi dari infeksinya tidak lebih dari 2 hari. Sedangkan kalau ventilator associated pneumonia sudah pasti pasien tersebut diintubasi, dia mengalami hospital acquired pneumonia, pasiennya diintubasi ya, atau mendapatkan ventilasi mekanis lebih dari 48 jam. Nah, epidemiologinya saya coba mencari data-data CAP dari Asia Tenggara. Sebagian besar Asia Tenggara saat ini belum mempublish penelitian mengenai CAP, termasuk di Indonesia, Brunei, Myanmar, Kambodia, Laos, dan Vietnam. Dan sebetulnya etiologi dari CAP berbeda menurut geografis dan setting demografinya. Di Amerika saja CAP ini insidensinya 5-11 per 1000 penduduk, 22-42% dia membutuhkan perawatan rumah sakit dengan mortalitas 5-12%. Dan HAP memiliki mortalitas yang lebih tinggi daripada CAP. Nah, ini juga insidensinya di Amerika, CAP 1 dari 100 orang, sedangkan HAP lebih sedikit lagi, 8 kasus per 1000 penduduk, tetapi memang mortalitasnya lebih tinggi. Nah, ini insidens HAP dan VAP, keduanya HAP dan VAP sekitar 22% dari infeksi yang dapat di rumah sakit. Dan VAP memang terjadi pada hampir 50% pada pasien yang membutuhkan ventilasi mekanis apabila dia sudah dirawat lebih dari 2 hari. Tapi insidensinya ini berbeda dari tiap negara dan tipe-tipe ICU-nya. Mortalitas di HAP di ICU itu hampir sama dengan VAP-nya. Dan penyebabnya memang dibandingkan memang lebih tinggi pada HAP ya, sekitar ventilated HAP 32,9%, ventilated acquired pneumonia VAP 27%. Dan dengan adanya pneumonia ventilator ini yang disebabkan oleh mechanical ventilation ini, lama rawatnya lebih panjang dan tentu saja cost-nya juga akan lebih banyak. Nah, etiologinya, penyebab utamanya adalah wide spectrum patogen dari bakterial. Yang paling sering adalah Pseudomonas, enteric gram negatif bacilli. Etiologinya, penyebab utamanya adalah wide spectrum patogen dari bakterial. Yang paling Staphylococcus MRSA, MMSA, antimicrobial flora. Penyebab utamanya adalah wide spectrum patogen dari bakterial. Yang paling Staphylococcus MRSA, MMSA, antimicrobial flora. Oke, ya maaf tadi ada suara sedikit ya, saya tidak tahu dari mana. flora antimikrobialnya dan resisten pattern-nya memang berbeda tiap negara, tiap regional, bahkan tiap rumah sakit. Bahkan di ICU pun berbeda. Mungkin ICU anak dengan ICU dewasa berbeda. Banyak infeksi yang disebabkan oleh polimikrobial dan umumnya virus dan patogen jamur sangat jarang dan terjadi pada pasien-pasien yang imunokompeten. Ini adalah CAP, penyebabnya adalah yang paling banyak adalah Streptococcus pneumonia, Haemophilus influenza, ada atipik juga. Sedangkan kalau VAP, HAP adalah gram negatif. Nah, ini adalah etiologinya saya dapat dari satu buku textbook. Memang di luar negeri, di CAP itu paling banyak disebabkan oleh Streptococcus pneumonia. Tapi untuk di Indonesia, ini ada satu penelitian mengenai virus dan gram negatif yang mendominasi etiologi CAP, itu adalah paling sering ditemukan, ya. Gram negatif ternyata merupakan penyebab paling sering CAP di Indonesia. Nah, ini adalah virus-virusnya. Ini adalah penelitian yang beberapa tahun yang lalu, tapi sekarang pasti sudah didominasi oleh SARS-CoV-2, ya. Dan dilihat di sini bakterianya memang kebanyakan adalah gram negatif. Nah, bagaimana dengan patologi dan patogenesisnya pada pneumonia? Itu adalah akibat invasi dari mikrobanya itu ke saluran napas bagian bawah. Ya, biasanya rutenya yang paling umum adalah inhalasi dari patogen airborne atau aspirasi dari gaster dan flora normal nasofaring, misalnya pasiennya dengan refleks batuk yang kurang, lalu ada penyebaran dari tempat lain. Lalu terjadinya pneumonia dan yang memperberatnya itu adalah balance antara bakterial, yaitu virulence inoculum size-nya, dan host factor-nya. Host factor seperti daya tahan tubuh, yaitu imun respon baik fisik spesifik dan non-spesifik. Lalu yang terjadi adalah alveolus dan interstisium dari paru akan terisi sel-sel radang dan fibrin. Nah, ini adalah faktor-faktor predisposisi seseorang untuk mendapatkan pneumonia. Biasanya, misalnya pada pasien dengan chronic obstructive pulmonary disease seperti asma, PPOK, paling sering terjadi disebabkan oleh Haemophilus influenza, Streptococcus pneumonia, Legionella, Moraxella. Pada pasien orang yang sering kejang, itu sering terjadi pneumonia aspirasi. Pada pasien yang imunocompromised, Klebsiella, Streptococcus pneumonia, alkoholism, Klebsiella juga, HIV juga sering disebabkan oleh Streptococcus pneumonia, dan komorbid yang pasien orang tua paling sering disebabkan oleh Chlamydia pneumonia. Nah, bagaimana kita untuk mendiagnosis pneumonia ini, ya? Jadinya yang paling pertama adalah riwayat perjalanan pasien, ya, dari anamnesis dan pemeriksaan fisik. Oleh sebab itu, kita memang harus melakukan anamnesis yang rinci dan terarah dan pemeriksaan fisik yang lengkap. Beberapa gambaran kadang-kadang dapat menunjukkan etiologi yang khusus. Misalnya, pleuritic nyeri dada, pleuritic chest pain, onsetnya akut, demamnya tinggi, paling sering disebabkan oleh Streptococcus pneumonia. Lalu ada keterlibatan dari multisistem, misalnya kulit dan lain-lain, dan ada riwayat berpergian, ada Legionella pneumophila, ini adalah atipik. Jangan lupa ada gambaran tertentu seperti komorbid, seperti PPOK, pasien dengan imunodefisiensi, pasien dengan riwayat kemoterapi, dan lain-lain. Nah, lalu pemeriksaan penunjangnya apa yang kita lakukan? Yang paling mudah adalah kita melakukan chest X-ray. Jadinya fototoraks merupakan sarana yang nomor satu yang disarankan dari semua guideline. Pada fototoraks dan didapatkan konsolidasi, air bronkogram, kavitasi, dan dapat ditemukan para pneumonia efusi. Dari pemeriksaan darah dapat didapatkan peningkatan sel darah leukosit, ya, shift dari hitung jenis shift to the left. Dan jangan lupa untuk chemistry kimia yang darah yang lain, kita juga harus memeriksa fungsi hepar, fungsi ginjal, dan kadang-kadang kita memerlukan marker inflamasi seperti prokasiltonin atau CRP. Kalau pasien dalam keadaan berat, memang sebaiknya kita lakukan blood gas analysis. Jangan lupa elektrolit serum juga kita periksa, apalagi pasien sudah tua. Dari guideline ATS ITSA juga menyarankan untuk menggunakan pneumococcal urinary antigen test untuk mendeteksi C. polysaccharida antigen dari Streptococcus pneumonia. Begitu juga dengan Legionella, karena memang 30% bakterianya adalah atipik. Nah, ini adalah gambaran yang khas ya, pneumonia, tapi sayang sekarang saya sudah jarang sekali mendapatkan gambaran ini. Kebanyakan pneumonia COVID. Nah, lalu apa yang kita lakukan? Kita sebelum memberikan antibiotik, kita mengambil sputumnya untuk dilakukan mikroorganisme kultur dan sensitivitas. Jangan lupa kita juga harus memikirkan mikroba atipik, ya. Nah, untuk di era sekarang ini, semuanya sudah molekuler, beberapa laboratorium diagnosis menggunakan multiplex PCR untuk lebih jelas lagi dan lebih cepat atau rapid identifikasi dari bakteri-bakteri tersebut, karena dengan menggunakan multiplex PCR dapat dengan cepat dan tepat mendeteksi DNA dari bakteri dan virus tersebut. Ya, jadinya ini langsung dapat 2, bakteri juga, virus juga. Nah, ini adalah diagnosis testingnya untuk CAP, ya. Untuk fototoraks masih 65-85% masih bagus, dan CT scan merupakan gold standar, ya. Tapi memang sebaiknya memang tidak dilakukan secara rutin, ya, walaupun bagus, ya. Kultur darah 10-20%, sputum pewarnaan gram 40-100%, dan lain-lain. Nah, ini adalah ATS ITSA rekomendasi diagnosisnya dari ATS ITSA yang terbaru. Bisa dilakukan kultur darah pada pasien yang dicurigai HAP/VAP. Ya, pada VAP biasanya dilakukan non-invasive sampling dengan semi-kuantitatif culture, ya, dari endotrakea aspirasi. Sedangkan kalau HAP juga non-invasif sputum sampling sebelum pemberian terapi empirik, ya, dengan induksi sputum, spontaneous expectoration, nasotracheal suctioning. Lalu bagaimana biomarker untuk di ATS ITSA? Harus sesuai dengan kriteria klinis dan tidak direkomendasikan atau tidak disarankan menggunakan prokasiltonin, estrem atau CRP. Kita boleh melakukan dengan clinical pulmonary infection score yang merupakan scoring semi objektif untuk mendiagnosis VAP. Tapi pada ATS ITSA tidak direkomendasikan. Nah, sebelum kita pada saat kita melihat pasien, kita juga bisa melakukan severity assessment untuk menentukan di mana pasien itu akan ditempatkan. Ya, jadinya sekaligus kita mengkategorikan pasien sesuai dengan kelompok-kelompok prognostiknya, dan ini dapat membantu kita untuk menentukan manajemennya. Yang pertama adalah saya akan membahas 2 hal yang paling sering kita gunakan, yaitu PSI dan Curve 65. PSI ini awalnya dari Pneumonia Patient Outcome Research Team atau PORT Project. Ini sebetulnya dia biasanya digunakan untuk memprediksi mortalitas jangka pendek pasien-pasien dengan CAP. Dikategorikan kelas 1 sampai kelas 5 berdasarkan 20 variabel yang berbeda. Sudah dilakukan lebih daripada 38.000 pasien yang sudah dengan CAP. Nah, ini adalah skornya, cukup akurat ya. Kita bisa menentukan pasien akan dirawat di mana, apakah di ruang rawat biasa atau di ruang ICU, dan sekaligus mortalitas, kemungkinan prognostik mortalitasnya. Tempat perawatan juga akan menentukan pemberian antibiotik yang menentukan antibiotik yang akan diberikan. Lalu yang kedua adalah curve 65, merupakan alternatif potensial selain dari PSI. Yang dilihat adalah pasien tersebut apa adanya konfusi, kadar urea, ya, respiratory rate, diastol, tekanan darah sistolik dan diastol, dan usia dari 65 tahun, ya. Dan dibagi menjadi low, intermediate, atau high. Ini digunakan sudah lebih dari 1000, jadinya lebih banyak dari PSI. Nah, ini adalah stratifikasi curve 65, low mortality, ya, moderate mortality, nah dirawat di rumah sakit, high mortality, ini adalah severe pneumonia yang sebaiknya kita rawat intensif. Ini adalah salah satu jurnal yang membandingkan PSI curve 65, CRB 65 di Singapura. Jadinya dibandingkan, ternyata PSI memang lebih reliable untuk stratifikasi severity dan prediksi mortality di antara pasien-pasien CAP di Singapura. Ini juga PSI setelah 10 decade setelah 1 dekade, bagaimana ternyata masih baik ya untuk akurasi prognostik dan lain-lain. Nah, di ATS-ITSA juga dikenal adalah kriteria mayor dan minor yang menentukan pasien ini apakah dirawat di ruang ICU apa tidak. Lalu yang terakhir adalah pengobatan, yaitu pasti sudah tentu bakteri kita berikan antibakteri. Karena etiologi penyebabnya itu lama hasilnya, maka pada saat pasien masuk ke dalam sebelum dirawat, dia masuk ke dalam IGD, ya, harus mendapatkan antibiotik dosis pertama. Berdasarkan apa? Berdasarkan kemungkinan bakteri yang terjadi pada pasien tersebut. Kita berdasarkan dari pemeriksaan anamnesis, pemeriksaan fisis, dan pemeriksaan penunjang. Nah, antibiotik yang inisial ini secara empiris, ya, berdasarkan lokal patogen patterns, ya, pola kuman patogen dan resistensinya. Nah, ini sebelum kita mengetahui antibiotik apa yang kita berikan kepada pasien, kita harus mengetahui faktor risiko. Faktor risiko untuk terjadinya multidrug resisten. Ada VAP, HAP, lalu ada yang MDR VAP, HAP, dan ada MDR yang VAP, MRSA, VAP, HAP, dan MDR Pseudomonas VAP, HAP. Dari semuanya didapatkan kesamaan satu, yaitu riwayat penggunaan antibiotik dan HIV, ya, bukan oral, dalam 90 hari terakhir. Sedangkan kalau yang VAP cukup banyak, ya, rata-rata pasien dirawat sebelumnya atau pernah ada cuci darah. Nah, ini adalah inisial treatment strategi pada pasien dirawat dengan CAP. Saat ini dibagi berdasarkan severity-nya dan resiko terjadinya resistensi obat. Misalnya dibagi 4, yaitu dibagi 5, ya. Standar regimen, pernah ada riwayat MRSA, pernah ada riwayat ditemukan kuman Pseudomonas aeruginosa, lalu pasien pernah dihospitalisasi dan memiliki faktor risiko untuk terjadinya MRSA atau Pseudomonas. Lalu pasiennya dibagi 2, non-severe dan severe. Ya, jadinya kalau misalnya ini adalah standar regimennya, kalau pasien memiliki resiko masing-masing seperti MRSA, Pseudomonas, ya, maka dapat diberikan obat-obat yang mengcoverage MRSA atau Pseudomonas, ya. Dan sebelumnya jangan lupa dilakukan kultur untuk mencari kuman penyebab. Nah, ini adalah pilihan empirik untuk pasien-pasien pneumonia yang di ICU. Memang sebaiknya berdasarkan epidemiologi lokal dan patogen tersebut yang menyebabkan pneumonia. Jadi memang harus diketahui pola ICU, pola bakteri ICU tersebut. Mungkin saja berbeda dengan rumah sakit, ya. Karena kenapa? Karena pada ICU beda individual, faktor mikrobanya, obat-obatan dan lain-lain. Nah, ini adalah penyebab perbedaannya, ya. Seperti ada komorbidnya, severity, dan ada ekspajanan alat-alat medis. Lalu ini adalah faktor mikrobanya, ada gram negatif, gram positif. Lalu obat-obatannya, kita harus melihat antibiogramnya, efficacy safety-nya, penetrasi ke jaringannya, PKPD, dan ini adalah yang lain-lainnya. Nah, ini adalah untuk VAP, ya. Satu, kita memang harus menggunakan antibiogram untuk menggait kita, memandu kita untuk pengobatan empirik. Pasti yang saya tekankan lagi, pola kuman ICU dari satu rumah sakit berbeda dengan rumah sakit lainnya. Tiap provinsi pasti berbeda-beda juga. Jadinya memang sebaiknya tiap rumah sakit memiliki antibiogram, ya, berdasarkan pola resistensinya, ya, yang diupdate secara berkala. Ya, karena kenapa? Antibiogram itu adalah bersifat lokal, hospital spesifik, unit spesifik, population spesifik ideal, ya, misalnya VAP pasti berbeda dengan CAP atau HAP, dan memang harus secara reguler diupdate, ya. Dan regimen empirik ini sebaiknya mengcover Staphylococcus aureus, Pseudomonas aeruginosa, dan gram negatif lainnya. Nah, ini juga apabila untuk kita menduga pasien tersebut ada Pseudomonas aeruginosanya dan gram negatifnya, maka kita menggunakan dua macam obat, ya. Dua macam obat apabila terjadi ada satu atau lebih hal-hal di bawah ini. Seperti faktor risiko untuk terjadinya MDR VAP, resisten gram negatif yang lokalnya lebih dari 10% untuk penggunaan obat yang single atau tidak diketahui, dan pasiennya memiliki gangguan struktur paru seperti bronkiektasis atau cystic fibrosis. Tapi kalau misalnya tidak ada ini semua faktor risiko MDR, ya, ada 1, 2, 3, 4, 5, tidak ada ini, maka boleh kita berikan satu jenis obat saja. Nah, ini, ya, memang kalau misalnya pasiennya tidak ada indikasi untuk kita berikan atau pasiennya terjadi MRSA, sebaiknya kita berikan anti Pseudomonas, ya, yang sensitif yang MMSA, yang memiliki aktivitas MMSA seperti pipetazol, cefepime, levofloxacin, imipenem, dan meropenem. Hindari aminoglikosida, karena memang aminoglikosida ini nefrotoksik, ya, dan penetrasi ke parunya kurang baik. Hindari colistin, ya, karena colistin ini merupakan last bullets, ya, obat yang terakhir. Ini adalah pilihan antibiotiknya, anti Pseudomonas beta-lactam, dan kalau misalnya ada resiko MRSA, kita bisa tambahkan vancomycin atau linezolid, ya. Kalau dia ada resiko untuk MDR, ya, kita tambahkan ini lagi, ya, ciprofloxacin, levofloxacin, amikisin atau blamicin, gentamicin, dan polymyxin, ya. Nah, bagaimana dengan HAP? Hampir sama. Kita menggunakan antibiogram, ya, untuk menggait pengobatan empirik kita. Karena tadi antibiogram itu bersifat lokal, hospital spesifik, unit spesifik, populasinya yang spesifik, dan secara reguler di-update. Dan pengobatan empiriknya sebaiknya mengandung Staphylococcus aureus, Pseudomonas aeruginosa. Nah, ini juga hampir sama, ya. Apabila dia ada satu atau lebih di bawah ini kita berikan 2 macam obat. Misalnya faktor risiko untuk MDR, high risk untuk mortalitas, misalnya dia memakai ventilator mekanik atau terjadi septic shock, ada structural lung disease, ada bronkiektasis ya, atau pada gram pewarnaan gramnya dia didominasi oleh gram negatif. Kalau cuman hanya kalau tidak ada ini semua, kita boleh beli satu macam obat. Ya, hampir sama kita bisa berikan anti pseudomonas ya, pipetazol, cefepime, levo, imipenem, meropenem, hindari aminoglikosida dan kolistin. Ini pilihannya untuk HAP ya, dibagi 3, tidak ada risiko untuk mortalitas, tidak ada risiko MRSA, ini obatnya. Sedangkan dia tidak ada resiko tinggi mortalitas ya, tidak menggunakan ventilator, tidak ada septic shock, tapi dia memiliki resiko MRSA ya. Kita pilih ini, salah satu ini dan salah satu dari bawah ini ya. Lalu kalau misalnya dia ada resiko mortalitas yang tinggi ya, kita pilih 2 di bawah ini dan di 1 di bawah ini. Jadinya 3 macam obat. Ini hampir sama. Nah, ini untuk setelah kita dapat kumannya keluar hasilnya dan didapatkan kumannya apa. Nah, ini namanya terapi definitif ya. Jadinya yang harus kita lakukan adalah deeskalasi, lalu kita mengkonfirmasi kumannya apa dan dia cocoknya dengan obat apa ya. Jangan lupa kita harus memikirkan farmakokinetik dan farmakodinamik. Nah, kalau misalnya ini adalah salah satunya kuman yang definitif, kalau misalnya hasilnya didapatkan Pseudomonas aeruginosa, ya. Kalau misalnya dia kita bisa berikan hanya satu macam obat kalau misalnya masih susceptible dan tidak ada septic shock dan resiko mortalitasnya rendah. 2, kalau misalnya pasiennya septic shock atau resiko mortalitasnya tinggi. Jangan menggunakan aminoglikosida dan lihat kombinasi pasiennya, kombinasi hasil kulturnya dilihat dari MIC-nya. Nah, ini contohnya ya, kalau MMSA kita bisa berikan oksisilin, cefazolin, MRSA kita bisa berikan vancomycin dan linezolid. Pseudomonas kita bisa berikan sesuai dengan susceptibilitasnya, begitu juga dengan ISBL. Kalau misalnya Acinetobacter kita bisa berikan ampisulfa, ya. Kalau misalnya berat bisa kita combine dengan polymyxin IV. Nah, ini contohnya kalau Streptococcus kita masih bisa masih sensitif terhadap amoxicillin, benzoxylin, chlamydia pneumonia, clarithromycin dan lain-lain. Nah, ini untuk yang VAP ya. Hampir sama, ini MRSA, anti pseudomonas aktivitas dan gram negatif dengan aktivitas anti pseudomonas. Nah, jangan lupa kita harus melakukan pengobatan secara empiris pada populasi yang istimewa ya. Ini adalah kenapa kita harus melakukan pengobatan empiris pada populasi tersebut. Kita harus memikirkan the most likely etiological agents. Jadi the most likely etiological agents ya. Kadang-kadang dia berbeda dengan yang general population yang lainnya. Ya, begitu juga dengan HAP. Kalau HAP dia membutuhkan spektrum antibiotik yang luas. Kalau gram negatif kita memikirkan untuk Pseudomonas, E. coli, Klebsiella, Acinetobacter. Sedangkan kalau gram positif kita memikirkan MMSA atau MRSA. Nah, ini tadi sudah saya sebutkan pada HAP kita memang harus hati-hati pada untuk lokal pattern ya dan resistensinya memang kita berikan harus broad spectrum ya. Begitu juga pada orang-orang yang dirawat di nursing home ya, tapi memang tidak ada perbedaan bermakna untuk obat-obatannya. Pasien dengan chronic respiratory infection seperti pada COPD, PPOK atau cystic fibrosis. Jangan lupa pasien kita lihat previous antimikroorganisme yang sebelumnya. Dan apa yang kita berikan? Kita memberikan gram negatif organisme cover, ya. Seperti kita berikan cefalosporin, beta-lactam atau carbapenem dengan pseudomonas yang obat yang mengcover pseudomonas. Ya, pada pasien imunokompromis itu memang terjadi peningkatan resiko untuk terjadinya pneumonia. Apalagi kalau misalnya pasiennya imunokompromis, ada defisiensi seluler imunitas, dia menjadi predisposisi virus, bakteri, jamur dan protozoa. Ya. Nah, dengan adanya berkurangnya imunitas humoral, sering menjadi predisposisi bakteri, khususnya Streptococcus aureus, Streptococcus pneumonia dan H. influenza. Sehingga first line empirical regimens ya kita berikan seperti sebaiknya broad spectrum, gram positif dan gram negatif. Jangan lupa kita pikirkan jamu dan pneumocystis jirovecii. Nah, bagaimana pasien-pasien yang ada gangguan di saluran napasnya seperti alkoholik, pasien dengan kejang, stroke, atau ada pernah operasi di dental gigi atau gangguan di muskular. Kita harus memikirkan bakteri anaerobik. Kita bisa berikan beta-lactam atau cefalosporin, kita tambahkan metronidazole. Nah, untuk follow up untuk kasus-kasus yang komplikasi biasanya membaik dalam 5 hari terakhir. Jadi 5 hari pertama. Jadi kalau misalnya dia tidak ada perbaikan 2-3 hari, kita sudah harus memikirkan ada apa dengan pasiennya, ya. Dan pasien pneumonia biasanya diobati paling sedikit 5 hari. Nah, kita mengenal adanya switch terapi dari IV ke oral apabila pasiennya stabil secara hemodinamis dan bisa minum obat secara oral, ya. Apabila dia tidak demam 48 jam dan dia stabil, sudah tidak takikardi, sudah tidak hipotensi, tidak takipno, hipoksia, dan lain-lain. Dan pasiennya memang harus direview 6-8 minggu untuk dilihat. Biasanya kita melakukan chest X-ray. Kalau pasiennya tidak respon terhadap manajemen yang inisial kita harus lihat apakah dia antibiotiknya tidak adekuat, atau ada gangguan obstruksi, atau ada pasiennya imunodefisiensi. Dan jangan lupa kita lihat ada komplikasinya, apakah ada parapneumonia infusi, emphysema, abses paru, keganasan, atau ada cryptogenic organizing pneumonia. Nah, ini adalah penyebab pneumonia, kenapa dia susah untuk perbaikannya atau tidak menjadi perbaikan. Misalnya ada viral pneumonia, legionella, bahkan TB bisa. Neoplasma, ada CHF, pulmonary emboli, atau ada hal-hal lain, atau ada toksisitas obat. Nah, ini adalah faktor risiko untuk outcome yang jelek dari CAP, ya, seperti ini. Nah, untuk prevensinya, vaksinasi bisa kita yang saat ini untuk melawan Streptococcus pneumonia, ya, dapat mencegah pneumococcus disease atau invasive disease karena dapat meningkatkan imunogenisitas kita. Jangan lupa kalau pasien masih merokok, kita harus melakukan edukasi untuk pasien untuk berhenti merokok. Ya, terima kasih, Dr. Hedi. Saya kembalikan kepada moderator.
Terima kasih Dr. Fathia atas presentasi yang sangat menarik. Untuk acara selanjutnya adalah diskusi. Mungkin ada yang mau bertanya dari peserta. Kita lihat sudah ada 131 peserta yang bergabung pada siang hari ini. Kalau mau bertanya bisa langsung diketik di kolom chatnya. Nanti saya bacakan. Tapi sementara belum ada yang bertanya, Dr. Fathia, saya boleh mengajukan beberapa pertanyaan, Dok?
Ya.
Kalau Dr. Fathia kan sehari-hari bekerja di Rumah Sakit Persahabatan nih sebagai salah satu pusat rujukan COVID yang dari yang pertama ya. Nah, itu bagaimana pengalaman selama pandemi ini, Dr. Fathia? Apakah pneumonia juga banyak yang terjadi dan bagaimana pengobatannya?
Ya, jadinya selama pandemi ini, selama 7 bulan saya memperhatikan baik di ruang yang paling sering adalah dua ruangan. Ruangan HCU kita yang di Pinere dan ruangan ICU. Itu banyak untuk pasien-pasien yang eh, akhirnya perburukan, ternyata ditemukan ada bakteri lainnya yang numpang memperburuk penyakit pasiennya. Yang paling sering dijumpai adalah Pseudomonas aeruginosa, Klebsiella dan E. coli. Seperti itu. Jadi memang apalagi di ICU. ICU kita lumayan banyak pasien-pasien yang pada akhirnya minggu kedua itu terjadi super disposisi bakteri selain virusnya. Mungkin virusnya sudah tidak ada lagi, tapi karena memang jejas yang diakibatkan oleh virusnya itu menjadikan kerusakan paru yang cukup luas, jadi pasien lebih rentan, jadinya bakteri gampang masuk. Apalagi pasien-pasien kita rata-rata mendapatkan medical devices ya, seperti IV line, CVP, ventilator mekanik dan lain-lain.
Dan kalau saya boleh bertanya juga, apakah yang dilakukan di Rumah Sakit Persahabatan, apakah rutin dilakukan untuk kultur? Ada pasien-pasien yang dengan COVID ini dan pneumonia juga.
Ya, dan kalau misalnya pasien yang COVID sendiri tidak langsung dilakukan kultur. Apabila dia terjadi perburukan, perburukan dan peningkatan tanda-tanda klinis adanya infeksi sekunder bakteri, baru kita lakukan kultur darah dan kultur sputum.
Nah, ini Dokter Fatia, mungkin dokter-dokter yang lain juga, peserta yang lain juga ingin bertanya. Ini ada dari Dr. Farid Trofian Syahnur. Izin bertanya, untuk pemeriksaan foto ronsen kontrol sebaiknya dilakukan beberapa hari atau tergantung dari klinisnya. Terima kasih, Dok.
Oke. Jadi selama pasien dirawat, ketika kita sudah mendiagnosis pasien dengan pneumonia, kita harus memperhatikan keadaan pasien dalam waktu 24 jam, 48 jam, dan 72 jam. Yang pertama kita harus melihat keadaan klinisnya dulu, apakah sudah perbaikan apa tidak. Jadinya tadinya pasiennya sesak, menjadi tidak sesak, kebutuhan oksigennya tadinya meningkat, sudah menurun dan lain-lain. Dan apabila sudah terjadi itu, kita sebaiknya melakukan switch terapi. Nah, selain kita melihat klinis, kita juga harus melihat dari fototoraksnya. Jadinya menurut saya fototoraks bisa dilakukan minimal hari ketiga pemberian antibiotik disertai dengan perbaikan klinis. Tapi kalau memang klinisnya tidak ada perbaikan, kita juga sebaiknya melakukan pemeriksaan fototoraks juga selain pemeriksaan fisis parunya untuk mengkonfirmasi apakah misalnya ada pneumotoraks dan lain-lain.
Ya, oke, terima kasih, Dok. Berikutnya pertanyaan dari Dr. Sukarti, spesialis paru MKes. Dr. Sukarti bertanya, mohon bagaimana pola kuman pada pasien-pasien COVID-19 dengan infeksi bakterial? Kuman apa yang paling banyak?
Ya. Tadi yang saya sebutkan sudah beberapa kasus yang kita sudah bawakan di forum di morning clinic kita. Pasien-pasien yang HAP dan VAP paling didominasi bakterinya oleh gram negatif, yaitu Klebsiella pneumonia, Pseudomonas dan E. coli, seperti itu.
Dan penanganannya biasanya antibiotiknya apa tuh, Dokter Fatia?
Ya, antibiotiknya yang pertama kita berikan adalah broad spectrum dulu, tapi kita sudah menduga kemungkinan besar pasien ini adalah disebabkan oleh gram negatif. Nah, lalu dilakukan sebelumnya kita lakukan kultur darah dan sputum. Kalau sudah ada hasilnya 5-7 hari baru kita lihat dan kita sesuaikan. Biasanya sih sesuai.
Kalau nggak salah Rumah Sakit Persahabatan udah punya ini ya, pola kuman ya
Sudah ada pola kuman, tapi harus diupdate lagi mengenai COVID ini karena sedikit agak berbeda.
Ya, mungkin waktu sudah habis ya. Pertanyaan juga sudah tidak ada yang bertanya lagi. Kepada Dokter Fatia, saya ucapkan terima kasih
atas. Terima kasih Ibu Moderator, Dokter Heidi.
Ya, berikutnya adalah ada video dari PT MSD. Boleh langsung ditampilkan. Okay. Thank you. Still watching the webinar seminar for the facing the challenge of the treating bacterial pneumonia during the and after pandemic. Now we exit to the second session. We have Dr. Asop Kurup as a presentation. Dr. Asop Kurup completed his undergraduate medical training at the National University of Singapore. He continued to postgraduate training with a master in internal medicine from the same institution and acquired membership of the Royal College of Physicians, Edinburgh, UK. He is an infectious disease specialist in private practice and also a visiting consultant in the Department of Infectious Disease, Singapore General Hospital. Dr. Asop, please give your presentation. Thank you.
Yeah, hi. Can you hear me?
Yeah, I can hear you.
Yeah, okay. Well, maybe I can try my best because I'm accessing it on my mobile device. There is an issue with the link, and I don't have the setup on my laptop. So maybe I'll.
Yeah, you have your presentation here. We can see.
Yeah. I'm accessing it on the on my
Mobile.
on my handphone. I hope
okay.
my phone doesn't ring and cause problems with communication.
Yeah.
If it is loud and clear, I will proceed right now.
Yeah, is it loud and clear?
All right. Okay, yeah, all right. So a brilliant Sunday to everybody, and sorry for any delays I may have caused inadvertently. So it's my privilege today to talk about challenges in managing multi-drug resistant pneumonia. Well, it's a big challenge, no doubt. We have been unfortunate because we have had a steady alphabet soup of resistance in the recent past, and we have got to try our best to keep up with the science and what's been evolving in that direction. And so today I will talk about a new option and to give you some perspectives in that regard. So a brief outline of what I'm going to talk to you today is a little bit on the impact of antimicrobial resistance on hospital-acquired pneumonia and ventilator-associated pneumonia. And as you know, with all things when it comes to sepsis, we have to get it right as early as possible. And a little bit maybe about diagnostic challenges that we all face when we try to get that diagnosis as right as possible the first time round. And then the main crux of today's talk, which is the role of the new kid on the block, which is ceftriaxone tazobactam, in its new approved indication for pneumonia, for hospital-acquired pneumonia, for ventilator-associated pneumonia. So I'm going to start with a little case, and I thought that this might be able to illustrate the problem in a little bit more detail. And I can then bring you through aspects of the case and how we actually deal with a situation in real life. So we have an elderly male, and he has multiple medical problems as listed. He's diabetic, he's hypertensive, he's got coronary artery disease, and he's got asthma as well as chronic obstructive pulmonary disease. He also has a history of previous pneumonia before. There was, I think, at least twice in the last 1 year at least. And he presented again with fever, cough, and dyspnea for 10 days. So he was treated in another hospital prior to coming to us. He was treated in an overseas hospital. And they had actually thought that he had an exacerbation of bronchial asthma, and they gave him a course of steroids, including intravenous dexamethasone. And he also had empiric antibiotics, which included piperacillin tazobactam. And as well as subsequently, as he wasn't quite improving, they gave him intravenous meropenem, 500 milligrams Q12. So when he came to us, he was still unwell. He still had persistent fever, and he was having persistent cough. He was clinically febrile. His blood pressure was borderline. He was tachycardic, and his oxygen saturation was already requiring supplementation. And he had crepitations on auscultation of his left base. He was admitted into the intensive care unit for type 1 respiratory failure, and he was managed with intranasal and subsequently face mask oxygen therapy. And then septic workup was done, sputum cultures were sent, and those were the initial laboratories to tell you that he had evidence of sepsis. His white cell count was 14,000. The C-reactive protein was high at 82. He had renal impairment, as you know before, and his serum creatinine was 124, which brings us to his estimated GFR of 30 plus. So this evolving CT scans of the chest, and I apologize because there was some other than this, but I couldn't get all the records in time for this talk. And you can see from the scan here that he had the burden of pneumonia primarily on the left and the left base, and that is where he had the crackles that we heard on auscultation. So here's a common conundrum, because you have an ill patient in the ICU, an elderly person, and he has got this pneumonia with the background that I have told you. So the first question to you is, what would be your empirical antibiotic pending sputum cultures in your clinical practice? Would you go with intravenous colistin or intravenous polymyxin B? Or would you stick to meropenem, but because he was on 500 milligrams Q12, you might want to give a higher dosage? Would you use ciprofloxacin instead? Or maybe your first choice is cefepime? Or maybe you have some other combination of the above antibiotics that we have listed. Or maybe you even have another option altogether, and that is other. So kindly choose, maybe in the next 10 seconds, the right choice. Please proceed. Will there be a clock or something to tell me whether they are voting?
Yeah, there's a voting. Yeah, most people answer the meropenem but higher dose.
Okay. So I think that, if the most have already polled by now, there is no obvious, real, definite answer to tell you what is the choice. Because when it comes to this case, I think it will illustrate many points. And I just want to take it from here that IV colistin or IV polymyxin shouldn't be your choice, because there is a lot of data right now to tell you that colistin polymyxin Bs, they do not have the kind of concentration in the epithelial lining fluid for us to actually think that using them at standard dosings, let alone giving them at loading doses and higher doses, is going to get a lot of concentration in the lung. And on top of that, you're going to have a lot of side effects and toxicities with these drugs. So there might be some utility in all the other options, but then I will take you through the next few slides. So if you look at what guidelines would show, now this is just an example. This is the American 2016 Infectious Diseases Society of America's guidelines on HAP and VAP. And if you look at their risk factors for multi-drug resistant organisms that can cause ventilator-associated pneumonia, you can see that the patient in this case had already started to fulfill several, including the fact that he had evolving sepsis. He already had the use of antibiotics before he came into the hospital. And, it's not as if he was going into acute renal replacement therapy, but those are things that we would have to remain vigilant about. So the setup here is that this individual is a person who is at risk for multi-drug resistance, but we also need to know that mortality associated with inadequate initial antibiotic therapy in these critically ill patients who have either VAP or sepsis or bacteremia is going to be very challenging. And so there are many kinds of data and data sets that are out there, and I don't intend to belabor many, but this is an example for you, and you can clearly see the effect of initial adequate therapy as opposed to initial inadequate therapy and its impact on mortality. So we have to get it right for these kinds of people, but how do we get it right? We also have to understand, therefore, the prevalence of gram-negative pathogens in these kinds of conditions, like in this example, collected from respiratory tract infections in the intensive care unit. And this data set comes from the SMART database. And you can see that if we talk about the prevalence of gram-negative pathogens in the ICU, it divides like maybe 60% of the time you might get a gram-negative pathogen. And of that, it's teased apart between Pseudomonas aeruginosa, Klebsiella pneumoniae, and E. coli. So these are the percentages that are usually implicated. But on top of that, as times have evolved, you and I probably know in our various backgrounds where we are practicing that meropenem resistance have crept up over the last decade. And in this database, it shows that roughly 20% of the gram-negatives can be meropenem resistant. So now, these pieces of information so far telling us, you have to get it right the first time. You must be able to, help your patient survive. But at the same time, you are probably going to be dealing with a lot of drug resistance. So it's quite challenging to be able to want to know what that perfect drug or drug combination that would be. So coming closer to home, and this is our little data set from Singapore to show about carbapenem resistance in gram-negative bacteria. I would like to draw your attention to, I think, the bar which is in red, which would tell us about Pseudomonas aeruginosa resistance, which is in excess of 10%, 20%. So we do have these kinds of problems in our background, and it is useful for us to know what our antibiogram is and what is your antibiogram, because how you practice within your area would really depend on what kinds of cases you see. How I see my cases may be different from how you experience yours. Now, I just wanted to introduce you to the CDDEP website, and you can download this easily, and the reference is given to you in the slide set, which I've illustrated here. And you can literally pull up anything that you want. If you want to look at Pseudomonas aeruginosa and its resistance across the world, well, you can easily at a point, at a click of a mouse, you can get all this information, and it tells you what the resistance patterns, like for example here in India, as opposed to other countries, and various other kinds of information as well, including ESBL, including CRE. You can also get information on antibiotic utilization. So this is a useful resource for you, especially in centers where you get patients coming from all over the world. So knowing your backyard, knowing your own local antibiogram and the regional antibiogram is useful. Knowing on the right and the outcomes, you can see that it is very much important, because whether you have these kinds of resistant organisms, it surely will impact on your patient outcomes as elaborated on this slide, even though I think you might not be able to see the graphs so clearly, but I think the data is there for you to see. So it is what it is. And, the problem when we try to engage diagnosis is that a lot of times you and I are relying on cultures. So cultures is a real big headache, because it takes 3 days for us to get something, and something preliminary, if we are lucky, in 2 days. So we don't want to lose precious time. And I don't know what kinds of rapid tests that you have, but this is just an example of some of the rapid tests that are out there, including the multiplex PCR that is available from the respiratory samples, and MALDI-TOF that can be used to help the laboratory get your answer faster. And some of these methodologies, for example, can even give us the etiology and even resistance genes in a more rapid, real-time way, so that it can help clinicians. For example, the turnaround times can be between 4 to 8 hours. And it's very useful for us to be able to know what kinds of bacteria that we are dealing with. For example, Pseudomonas aeruginosa might be detected, and its resistance mechanisms could be elaborated, and that can guide antibiotic strategies in a shorter period than cultures can. So the slide is titled "The Beginning of the End of Empirical Treatment," but it is maybe nothing more than the writing on the wall right now. I think in real practice, we haven't got there. But I hope in the next 5 or 10 years, we won't have to still keep waiting. And this continues to be a conundrum for us across the world. So I want to now move on to talking to you about ceftolozane tazobactam. And I will come back to the case that we illustrated earlier on, and I will tell you why we chose this drug in the context of the patient that we talked about earlier. So this is an FDA, meaning the U.S. Food and Drug Administration's approved product in 2014. And it is a very powerful drug against gram-negative pathogens, primarily Pseudomonas aeruginosa, and it's efficacious against ESBL Enterobacteriaceae as well. Now, it is very potent against Pseudomonas aeruginosa isolates that have gotten many kinds of resistance mechanisms, whether that are AMP-C or those which have gotten loss of the outer membrane porin, or they have got issues with the upregulation of the efflux pumps. So the main mechanisms by which Pseudomonas aeruginosa evades the other kinds of drugs, then ceftolozane tazobactam is able to counter that. It has limited activity against gram-positive pathogens, but it has been shown in two studies, one in complicated urinary tract infections and the other in complicated intra-abdominal infections, to be equivalent to levofloxacin and meropenem respectively, and hence it has gotten its approval in the utility in these conditions. But do note that for these conditions, the dosage that has been recommended is 1.5 grams 8 hourly. So that is the experience that we have had using ceftolozane tazobactam, and then of course now we have a new indication for it in the treatment of respiratory infections. And one of the main issues when we discuss the treatment of any drug in pneumonia is the lung penetration issue. Now, I discussed this earlier in the context of colistin and polymyxin B, because an interesting and important concept is how much of the drug gets from the bloodstream and crosses across the alveoli and get into the epithelial lining fluid. And this is an important consideration because in ceftolozane tazobactam, which will be elaborated over here, this is the PK/PD data in patients with pneumonia receiving mechanical ventilation. And in this slide, you can see the doses over an 8-hour dosing interval. At 3 grams of ceftolozane tazobactam, it maintained its level not only in the plasma, but also in the epithelial lining fluid, which was well above the minimum inhibitory concentration of 4 and 8. And 8 is when it's considered intermediate. So the reason why the 3-gram dose was chosen subsequently in the registrational studies for pneumonia was to actually to be effective against organisms which could have higher MICs. Resistance isolates of Pseudomonas, for example, MICs of 8, for example. And therefore, if you have the 3-gram dose and these kinds of PK/PD modeling showed that the 3 grams is efficacious, then that is where, that is how you can actually drive the studies. Because people have learned in previous registrational studies of other drugs that were used in the past, in the recent past, to study against pneumonia, and they found that they did not perform as well, and part of the reason was because you were not getting the adequate dose. So this was the study design of this drug, which was ceftolozane tazobactam, which was 3 grams every 8 hourly, compared against meropenem 1 gram 8 hourly. Now, this enrolled people who were quite sick and people who were all mechanically ventilated. So this design actually is quite robust because they took quite a lot of people who are very sick. And I think that if you can see the, oops, I'm sorry, I think I pulled the slide across on my phone. Sorry, can you hear me?
Yeah, we can hear you.
Okay, I have a problem getting my slide for some reason. Could you just give me 5 minutes or 2 minutes? Let me get my slide back on again.
Okay. Mohon maaf pada peserta sebentar, kita tunggu Dr. Asop sedang memperbaiki slide-nya. 1 menit. Dr. Asap? Yeah.
Yeah, hi. I'm sorry about that, but can you hear me?
Yeah. Here and can hear you.
Okay, just give me 1 second. I think the sound is coming a little bit not quite right. Just 1 second, please.
Yeah.
Hello, can you hear me now?
Yeah.
Okay, yeah, sorry about that. Yeah, there was some technical issues.
Yeah. Yeah, you continue with.
Yeah, all right. Sorry about that. Okay, so I just move on to the aspect NP. Okay, all right. So just to take it on to the test of the primary efficacy endpoint was all-cause mortality at day 28. And the secondary endpoint was the clinical response, which was complete resolution or clinical improvement in signs and symptoms of the index infection at the test of cure, which occurred 7 to 14 days. So the way they wanted the duration of the antibiotics was up to 14 days, but I think that on average, people received it between 7, maybe 8 days. So the baseline characteristics between the two comparator drugs were equal, and you can see that it's elaborated over here. And the mean Apache score, as you can see, was at least about 17. So we do know that mortality in people who have these kinds of Apache 2 scores would be at least maybe about 25%. So the kinds of patients who were kind of critically ill in the ICU, and 100% of them were ventilated. So do note that about 13% of patients were deteriorating on their current therapy as they were enrolled into the study, and about 14% of patients had moderate or severe renal impairment. So when we look at the baseline lower respiratory tract pathogens in the modified intent to treat population, gram-negatives constituted approximately 60% of the pathogens in both arms, and ESBL and Pseudomonas aeruginosa were the most common ones. There were, in fact, XDR, Pseudomonas aeruginosa as well. That means they were pan-resistant, and it was small by way of numbers, 4 out of 10 in, I think, the ceftolozone tazobactam and 2 upon 5 in the meropenem arm. So when we talk about the outcomes, the aspect NP data showed the primary endpoint showed non-inferiority of ceftolozone tazobactam as compared with meropenem in the 28-day all-cause mortality. And when we tease out the data by strata, like persons who have ventilator-associated pneumonia, or persons who had ventilated hospital-acquired pneumonia. In other words, people who had pneumonia developed within the hospital, and then they required ventilation. After that, you can see that there was this significant trend of ceftolozone tazobactam at 24.2% as compared with meropenem at 37%. So I think by and large, we are trying to recognize this entity called ventilated hospital-acquired pneumonia. It has got potentially poorer outcomes as compared to VAP. So it's interesting to know that this drug had a favorable outcome in that subset. When we looked at all-cause mortality by select groups in the intent to treat population, you can see that there was no significant difference between the two drugs by way of several factors: age, renal function, renal clearance. But just to draw your attention to the previous unsuccessful use of antibiotics prior to the enrollment, and you can see that there was a trend favoring ceftolozane tazobactam in that regard. So this is the clinical cure rates outcomes, which was the secondary endpoint, and you can see that there was no difference between the two study arms. And defined by strata, again, there was a trend which showed that there was maybe a little bit more favorable outcome for ceftolozane tazobactam at 50.5% as compared with 44.4% for meropenem, but this was not statistically significant. Breaking down the results in clinical cure rates by per pathogen, again comparable across gram-negative pathogens teased out to Pseudomonas aeruginosa, Enterobacteriaceae, and ESBL organisms. But when you look at the microbiologic response by baseline pathogens, you will see the skew favoring ceftolozane tazobactam when it came to Pseudomonas aeruginosa at 79.3% of patients compared with 55.3% for meropenem. Like most beta-lactams for both drugs, severe reactions were not very significant, although it was described because we are engaging a rather critically ill population in the ICU, so outcomes had to be probably expected in that regard. But we don't usually see treatment-related adverse events that were severe, and it came up to approximately just 1%. And if you look at the most frequent types of treatment-related adverse events, is nothing very much above and beyond what you normally see for any kind of a beta-lactam drug. But do note that there is always Clostridium difficile and in whichever drug that you use, and do be aware of that consideration. An aspect of the HAP-VAP dosing, which was elaborated before, was the 3 gram utilization, which means 2 of the 1.5 gram vials, constituting 2 grams of ceftolozane and 1 gram of tazobactam, which is given over a 1 hour infusion period every 8 hours. And the duration that is intended for HAP and VAP is 8 to 14 days. Of course, the duration of therapy is guided by the severity of site of the infection and, of course, the patient's clinical and bacteriologic progress. Very, very important for you to know how to actually dose adjust the drug for patients with renal impairment. And here's a guideline. And we do have to tell you that it is important in an ICU patient whose renal function can be quite dynamic. So therefore, if you don't get the dosage right, then you might actually have poorer outcomes. So if in doubt, just go back to this or other similar product inserts to kind of follow the appropriate dosing. So when we come out of the aspect NP and look at other real-world experiences of ceftolozane tazobactam for multiply resistant Pseudomonas aeruginosa infections, and there has been many data sets that are already out there. The one on the left on the slide shows the 30-day mortality and attributable mortality for persons who actually had MDR Pseudomonas infections who were primarily having ventilator-associated pneumonia. And this was an experience out of the University of Pittsburgh in the USA. There was a 90-day clinical success of about 71%, and about 10% of the patients developed AKI or acute kidney injury. Now, the data was updated in the later part of 2018, and they had an abstract in ID Week where they looked at 73 patients. The previous data set looked at 21, and their 30-day mortality was 23%, and the clinical and microbiological success was 55 and 62%. And these kinds of data were quite similar to what was in the outcomes for the ASPECT NP data sets, which we talked about as well. Now, to your right of the slide, these are other data sets looking at 35 patients in 6 US centers who received ceftolozane tazobactam for more than 72 hours. And notably, 77% were resistant to all beta-lactams. And 77% received ceftolozane tazobactam monotherapy. The clinical success rate was nearly 75%. And it was reasonable for those who had pneumonia as well at 61%. Now, a further data that is elaborated is the one on the bottom from Gallagher, where he looked at 205 patients across 20 hospitals. And the clinical and microbiological success was in the 70s, but of note, he did say that there was significant improvement if the ceftolozane tazobactam was started earlier. That means within 4 days of culture collection. So all the more important to know that you got to get it right the first time. So I hope you haven't forgotten the first case that I talked about, an elderly gentleman who had that evolving pneumonia requiring intensive ICU admission and care with oxygen therapy. So why did we choose ceftolozane tazobactam over the other choices? And I know some of you had chosen carbapenem at maybe a higher dose. Well, we chose it because we know what our local epidemiology is like, and I showed you the data about the carbapenem resistance of Pseudomonas aeruginosa in the region and as well as in Singapore. This specific patient was also breaking through on carbapenem therapy. And even if the individual was on a low dose, it's very likely that he would be having carbapenem resistance already by now. So even if we give a higher dose, I think we're going to not get good outcomes, and we're probably just going to get more toxicity. So we thought, yes, a multi-drug resistant organism was likely. Potentially, it could be ESBL, or it could be a Pseudomonas aeruginosa. It could also be a CRE, who knows? But we do rapid rectal screens for all these patients who come to us from medical evacuation, and the rectal screen was negative. Not that that's a 100% correlate, but it was what it was. He had also been recently hospitalized, and he had been on steroid therapy with dexamethasone, and these are already known historically to be at risk for acquisition of Pseudomonas aeruginosa. And we also know data like this, which discuss the fact that among Pseudomonas aeruginosa isolates, tazobactam and other beta-lactams. So importantly, 61% of isolates were non-susceptible to cefepime, were also non-susceptible to meropenem. And 54% of isolates that were non-susceptible to piperacillin tazobactam or tazocin were also non-susceptible to meropenem. So if in this case, we were already talking about the susceptibility that could be reduced, compromised, or frankly resistant to the carbapenems listed here, we know that our other options were also going to be limited. However, 82% of isolates that were non-susceptible to other beta-lactams were fortunately susceptible to ceftolozane tazobactam. So we used the drug at 1.5 grams 8 hourly for his renal function, and he got out of the intensive care unit after 3 days. His fever lised, and he did not require supplemental oxygen with face mask. It came down to intranasal oxygen, and then we slowly weaned him out of that, and he was treated for a total of 10 days. Why 10 days? Well, I guess is a little bit of clinical, response, etc. So Maybe in future, the shorter the better, but it all depends on your individual patients. On the left is the sputum isolate, which grew Pseudomonas aeruginosa, and the antibiogram shows what we had anticipated, resistance to piperacillin tazobactam and to meropenem clearly shows that it is tough to use these drugs. For the same reason, it's very easy to develop resistance to the quinolones, and ciprofloxacin was also resistant. So therein, I did not show you the susceptibility to ceftolozane tazobactam, and it was susceptible. So this gentleman was lucky and he improved. So let me bring you quickly through a second case. This one had a much more severe pneumonia, and it was rather unfortunate because it followed a dental procedure. A 66-year-old gentleman who had a past history of diabetes and hypertension. And in an overseas hospital experience, what he had was a root canal treatment for his right lower molar tooth. And it was complicated by invasive odontogenic infection, resulting in very severe sepsis. In fact, he went on to develop a right neck and shoulder abscess, and that sepsis tracked down from the right jaw and caused a pneumonia, mediastinitis, and even a left empyema. So the initial cultures had isolated Streptococcus viridans and from the shoulder abscess as well. And, despite treatment with intravenous augmentin at 1.2 grams Q8 for 10 days, there was inadequate source control, which is very important to achieve. And this resulted in a long hospitalization with nosocomial infections coming up. And then he ended up having sputum and blood cultures isolating Pseudomonas aeruginosa. And he was treated with intravenous meropenem 1 gram 8 hourly for 7 days before coming to us. So his clinical course in Singapore was similarly complicated, but I summarized it in it for you. The first is he had a prevailing diagnosis of what we talked about earlier with that right odontogenic infection. And it was true, it was tracking through his right upper chest and shoulder. He had mediastinitis, left empyema and pneumonia, and he was, after all, a diabetic. So this was complicated by respiratory failure, and he ended up in the intensive care unit. The lower respiratory culture isolated not only Pseudomonas aeruginosa, but also an ESBL E. coli. Swab cultures from the right shoulder wound isolated Pseudomonas aeruginosa. Blood cultures were sterile. The CT scan of the neck and abdomen showed extensive subcutaneous swelling and edema in the neck. And I will show you that extensive consolidation in the lung in a minute, as well as significant ascites. So we talk a lot about antibiotics, no doubt, but extremely important for all of us clinicians to note is the importance of source control. The ascites was drained and cultures from this was repeatedly negative. The left empyema had to be drained. A thrombolytic agent was also used. The right neck shoulder wound was cleaned and a vacuum-assisted closure dressing was secured. He also had long lines which were removed, changed, and a urinary catheter replaced as well. This was the X-ray and the CT scan showing the bilateral severe pneumonia, and you can see the consolidation quite evident. So coming to question number 2, for hospital-acquired pneumonia implicating in this gentleman an ESBL E. coli and a Pseudomonas aeruginosa, and for your benefit, I have shown the organism Pseudomonas aeruginosa susceptibility, and it is susceptible to piperacillin tazobactam, ceftazidime, cefepime, meropenem, resistant to the aminoglycosides, and also susceptible to ciprofloxacin. So now I challenge you and ask you, what would be your choice in your current clinical practice, and which is the correct statement? Is it A, piperacillin tazobactam is an appropriate choice because it covers for ESBL E. coli and Pseudomonas aeruginosa, and so you can get this one drug to cover it all? Or you still prefer meropenem because it can adequately cover for ESBL E. coli, and it's also a good agent for Pseudomonas aeruginosa? Or would you opt for C, where you think that maybe you would use a combination therapy of ciprofloxacin and piperacillin-tazobactam, or D, ciprofloxacin and meropenem combination therapy instead? Or maybe now you will and may consider the use of ceftolozane-tazobactam. So don't feel pressurized just because this is an introduction to ceftolozane-tazobactam that you have to choose E and that is the only correct answer. Please feel free to choose what you think is the most appropriate choice in the next 10 seconds. I can't see the polling and I can't see them voting. So if anyone can see, can you shout out to me what is the majority audience choosing?
The majority choose A, piperacillin-tazobactam, 38%.
Okay.
And for B, meropenem, 8%, and ciprofloxacin, 4%. Ciprofloxacin and meropenem, 8%, and considered ceftolozane and tazobactam, 44%.
Okay, so that's a nice spectrum across the different choices, which would mean that it's good for the next few slides of discussion. So why did we again choose ceftolozane-tazobactam in this case? Well, I need to tell you that piperacillin-tazobactam is unfortunately not an ideal agent when it comes to invasive ESBL infections, and I will show you data on that in a minute. Meropenem, well, there is emerging data on association with the evolution of drug resistance in Pseudomonas aeruginosa. And specifically for us in Singapore, and I'm sure in many parts of the regional world as well, we have a lot of endemic high ESBL rates. And there is already very high meropenem utilization. And as you know, CRE is an emerging problem in that kind of a background. So when we have so much of meropenem use, we have to try to maybe risk stratify who might benefit from meropenem better rather than using it in all situations. And so why ceftolozane-tazobactam? Well, we have the data sets from the ASPECT NP data showing its efficacy in pneumonia. It's high potency against Pseudomonas aeruginosa and ESBL, and various mechanisms that it can overcome resistance in multiply resistant Pseudomonas aeruginosa, seen also from the real world data that was shown to you before, and potentially using ceftolozane-tazobactam maybe as a potential carbapenem sparing strategy in some situations. So just a brief on the Merino trial, which maybe some of you are aware of, but it was a trial that compared piperacillin-tazobactam versus meropenem for the definitive therapy of ESBL organisms, be it E. coli or Klebsiella from bloodstream infections. But it was meant to show potentially whether or not we could use piperacillin-tazobactam in lieu of meropenem. But unfortunately, the primary outcome, which was the all-cause mortality at 30 days after randomization, showed the skew to favor meropenem over piperacillin-tazobactam. So 12.3% of the pip-tazo patients versus 3.7% of the meropenem patients met the primary outcome. So we know that, unfortunately, for invasive ESBL infections, we cannot use piperacillin-tazobactam, but maybe we can use it for mild or low burden ESBL infections. So that's the kind of background for piperacillin-tazobactam and ESBL. How about carbapenem that I alluded to with its association with drug-resistant Pseudomonas aeruginosa? Well, this was published only last year, where ceftazidime versus carbapenems versus piperacillin-tazobactam were compared as single definitive therapy for Pseudomonas aeruginosa bloodstream infections, and it was a multi-site retrospective study. Now, while it showed no difference in mortality and no difference in clinical or microbiologic failure, it showed a higher rate of anti-pseudomonal drug-resistant infections associated with the use of carbapenems. So that is one of the problems with carbapenems and Pseudomonas aeruginosa. And this was, I thought, an interesting quote from someone whom I have a lot of respect for. Paul Sachs works in Harvard Medical School, and he's a professor of medicine and infectious diseases, also an authority on HIV, and he comes up with this blog called HIV and ID Observations, and it's published in the New England Journal's Journal Watch. And one of the quotes that he had on the 4th of August was the fact that meropenem and carbapenems are not good drugs for the treatment of Pseudomonas aeruginosa. And in his blog, he said resistance can develop quickly through alterations of porins or increased efflux pump activity. And the data that he alluded to was from the study that I showed there from Emerging Infectious Diseases of last year that talked about the emergence of carbapenem-resistant Pseudomonas aeruginosa across multiple US emerging infections program sites. So these are some of the evolving problems in that part of the world, as well as with ours, when we just use carbapenems for treatment of just about everything. So in this patient, we achieved clinical and radiological improvement using ceftolozane tazobactam at the ASPECT MP data approved dose of 3 grams 8 hourly. But do note that we also had a lot of source control, so we cannot get away from that. And that's an important principle across all kinds of clinical cases as well. Now, I don't know whether this slide projects to you properly, but I realized that on my slide, they are both interfaced. But the left is supposed to show the slide I showed you earlier about the pneumonia, and the right is supposed to show the mitigation and clearance of the pneumonia. Does it come across to you? It looks to me like they are both overlapping and you can't see the difference.
Yeah, they're overlapping, but we can see clearly.
Yeah, so, well, the images may not come across so well, but it shows the clinical improvement that I wanted to tell you. So here is the summary of ceftolozane tazobactam 3 grams in HAP and in VAP. So we have elaborated the fact that HAP and VAP is associated with high morbidity and mortality in ventilated patients, an independent risk factor for mortality. And we talked about the timeliness and appropriateness of initial therapy. And we showed that ceftolozane tazobactam clinical trials were conducted in difficult to treat patient populations. And they had used the data of 3 grams from phase 1 trials, showing that it was able to achieve concentration levels in the epithelial lining fluid and maintain dose across MICs over the entire dosing interval. So very critically ill patients in the ICU who are mechanically ventilated and who had high risk for mortality. And this data showed that at 28-day all-cause mortality, ceftolozane tazobactam was non-inferior to meropenem. And the favorable responses were observed in patients who are ventilated HAP and in patients who are failing current antibiotic therapy, a couple of take-home points. So despite the fact that we were using the higher dose of 3 grams, we did not also see higher toxicity, in particular, no significant neurotoxicity. So ceftolozane tazobactam provided broad coverage against common gram-negative pathogens, including certain resistant Pseudomonas aeruginosa and ESBL producers, and has a demonstrable safety profile, which is adequate. So in conclusion, a blurb that nosocomial infections, when we talk about pneumonia, HAP, with ventilated HAP or VAP, would be Staph aureus, Pseudomonas aeruginosa, and Enterobacteriaceae, which would be the primary pathogens that you might be thinking about. But it's extremely important for you to know your local antibiotic resistance patterns, and I showed you about the CDEP site that you can get more information from if you can't get regional and world data. And there are, therefore, a new agent that can offer treatment for HAP and VAP in this dilemma of multiple resistant organisms. We have got ceftolozane tazobactam, and you might want to consider this in certain specific instances, and I've showed you a couple of examples in cases where you can use it. and it has very strong activity against people at risk for multi-resistant Pseudomonas aeruginosa, and maybe you might also consider it as a carbapenem sparing strategy as well. But as with all drugs, be it new, old, current, or otherwise, it's important to have an antibiotic stewardship program in your institution, in your hospital, or in your practice, so that everything that you do is guided by science and you can do the best to your patient without harming the local ecology as well. Thank you very much for your kind attention, and I'm sorry for a couple of technical glitches. Thank you.
Yeah, thank you, Dr. Asok. Now we proceed to the discussion session. We have some questions, Dr. Asok. You can hear me?
Yes, I can hear you, yeah.
The first question is there any drug interaction, since in the critical ill patients we can use combined antibiotic or using another medicine? Is it the first?
Well, it's actually in various clinical guidelines, even the IDSA 2016 guidelines, and even in our own local antibody guidelines, we do have an entity for ventilated patients who have pneumonia, where there is a consideration for combination therapy empirically, because you don't know what you are going to be dealing with. And sometimes you have to consider all possibilities. And if it also includes persons who might be having MRSA infections as well. So in certain of these categories, then you might actually use a combination, and that kinds of combination can include a beta-lactam and maybe a quinolone as well. And sometimes we even use nebulized colistin, not intravenous colistin, but nebulized, so it gets directly into the lungs. So while there are some kinds of patients where you would think of using combination therapy, I think the best option would be to try to, if possible, to try to send samples for rapid testing if you have that kind of technology available, so that you can get the answers back as soon as possible, so you don't have to use so many of these drugs.
Okay.
And number two is you can de-escalate after you get your cultures, so that you know what bug you are dealing with, and that you don't keep using the combination therapy beyond the 72-hour mark.
Okay. And how about the interaction between the routine drug of the patient, like a hypertension or diabetes?
No, that should be fine, because it is a beta-lactam drug, so there is no significant drug-drug interaction in that regard.
Is it safe? Okay.
Yes.
Yeah. For the second question, is there any lethal dose for this drug?
Sorry.
Lethal dose.
Oh no, I think that they did look at the 3 grams in the context of, well, it is double the standard 1.5, and they did not find any significant association with mortality. Neurotoxicity was one of the concerns that we had, whether that was going to be a problem, but actually it wasn't. So we haven't seen any kind of association with mortality with the 3-gram dose. Now, whether there is a lethal dose with higher doses, I don't think that has been specifically studied. And then I think we would want to caution, because we do not have data for using it at higher doses than this. So I don't want to encourage the use of any dose higher than the prescribed dosing.
Okay. Can we use?
Can I ask one questions to Dr. Asok?
Okay.
Yeah, sure.
Okay. Yeah. Dr. Asok, this is the ceftolozane and tazobactam. And why the ceftolozane have to add the tazobactam? What is it, to strength or to prevent the resistance?
Yeah, because you also want to overcome the resistance mechanisms of Pseudomonas aeruginosa. So you cannot just use ceftolozane itself. You actually need the tazobactam as well. So if you just use the ceftolozane itself, it is not enough.
Okay. So the new drugs in for these combinations is I have to
you can use it. You can use CT.
This is the drugs.
Yeah,
Yes.
so you can say CT for short.
CT for short, and this is good to overcome the infections in our lungs because this is good penetrations in epithelial lining.
Lining fluid, yes. So that's correct. Yes.
This is just like the respiratory fluoroquinolone. It is just like respiratory fluoroquinolone.
In that sense, yeah. So it gets into the epithelial lining fluid in a good way. Yes.
Okay. Thank you.
But of course, you can't compare it with the respiratory fluoroquinolone because the antimicrobial susceptibility is different.
Yes.
Yeah.
Because in our hospital, the respiratory hospital, we have problems with the patients that already have so many antibiotics.
Yeah. So one of the problems is that you have to get the microbiologist to tell you what kind of antibiogram you're dealing with. And then once you have the discs for cephtalozane tazobactam, to also test the susceptibility to it as well. Because as with all drugs, you need to know that there is resistance also to cephtalozane tazobactam. And in large databases like in the University of Pittsburgh, where they have used it and so on, I think the resistance is up to 15%. So you will have to know that when you use this drug, it does not necessarily mean that it is going to be 100% success.
Yes.
You have to get the microbiology to to give you that. You can use it, but you also want to learn where what the resistance is like and where the resistance is coming from. Maybe it is from certain specific parts of the your experience, not everybody, and so on.
Okay, maybe next year the ATS ITSA can include these drugs into their guideline in HAP and VAP.
Yes. It is an alternative as in our guidelines we have put it as an option already.
Okay, so and this is for the VAP and HAP patient, right?
Yes, ventilator associated pneumonia, hospital acquired pneumonia, and ventilated hospital ventilated
hospital. Yes.
VAP and VHAP.
VAP, yes.
So what they showed in that data set was that people who were having VHAP were actually having worse outcomes, and that the drug was more suitable.
Yes.
I have just a small second of distraction to tell you about the epithelial lining fluid penetration of selected beta-lactam drugs in healthy individuals, just to give you a perspective.
Okay.
And the penetration is talked about penetration ratio, which is the ELF concentration to unbound plasma drug concentration. And that for cephtalozane tazobactam is 59%. And that for piperacillin tazobactam is 38%. Okay, so this data included imipenem, which was 55%. So you do have that kind of data to kind of inform your choices. There is a newer drug that is called ceftazidime avibactam. I don't know that you have that.
Yes.
Ceftazidime avibactam is 31 to 35% total drug concentrations. Yeah.
Okay, thank you.
Okay, Dr. Asok, what is the doses? Can we use 1.5 gram instead of 3 grams for hospital-acquired or ventilator-acquired patients?
Well, it really depends on what kind of minimum inhibitory concentration of the organisms that you are seeing in your local experience.
Okay.
The data for Aspect MP came on the heels of other failing studies of newer drugs that they tried to study for the use of pneumonia, and they found that they failed, primarily because they were not getting the adequate levels to counter resistant organisms. And that is why the Aspect MP used 3 grams instead of 1.5 grams. So while you can use that, maybe you have to really look at your local antibiogram and the kinds of MICs you are dealing with. Certain times you might have to dose adjust, obviously, for renal impairment, but I think primarily you're trying not to have any kind of suboptimal dosing, because outcomes are clearly linked to the right drug at the right concentration. So unless you have a good, different ecology, quite different from, many of us, it's very hard to imagine that you can get a lot of good outcomes with the 1.5 grams.
And for the patient with the renal complication, what is the dose?
Oh, yeah. So that is important. And that is the one thing that it's very important to highlight, because I don't know whether I can go back to my slide set, which I had earlier. Is it okay to go back to my slide deck? I had it on one of the slides.
Yeah.
Can I go to my slides?
Tolong slide-nya dibalikin.
Yeah, I think it may be, oops, not this one. Sorry, I forgot which particular slide it was, but it should be coming soon. And this is an important consideration. And yeah, here it is.
Yeah, this is okay.
So it's very important to know that for the renal patient, and it is very dynamic, because sometimes your patient might have, a day by day, there could be some kinds of adjustments in the critically ill patient. So you have to make sure that you titrate correctly.
Okay. Thank you.
Yeah.
There's some question from the audience, from Dr. Riana Agustin. How and when we do the escalation of the antibiotics for pneumonia patient with ASBL?
Yeah, so if you do know it's ESBL, well, it's not quite de-escalation, because you already know what you're dealing with, because it would be always a consideration for us, at least in our background, that we are going to have an ESBL patient, because the prevalence of ESBL is very high. It's about 30% to 40%. And in the kinds of patients coming from different parts of the world, it can also be quite high. So depending on the kinds of patients and what other resistant organisms that may have, what we do in our practice is we try to send off those various rapid testings as well, so that we can try to get the best kinds of combination, drugs, or maybe the only drug. So we can try to kind of quickly de-escalate once we have the results of rapid testing. If we can't, then based on culture. So whatever drug that you choose upfront, try to bring it and de-escalate it after you get your cultures back, or after you get your resistance mechanisms back, if that is good enough, and don't keep having it on. In a high burden ESBL infections, we try not to use ertapenem. We usually, as I mentioned, because of the Merino trial, we do not use piperacillin tazobactam for invasive ESBL infections. So some of these ESBL infections, we have the alternative as a carbapenem sparing strategy of using ceftolozane tazobactam. So some cases where we think, yes, it could be an ESBL, but we are also worried about other resistant organisms, then you can actually use ceftolozane tazobactam in lieu of using a carbapenem. But in some instances, you cannot be sure, and you're worried about many things. It's okay to want to use a carbapenem, for example, but then you try to streamline after that and see whether you can take away, because all of us in our shared background, I think we use a lot of carbapenems, plenty.
Yeah, thank you. For the last question from Dr. Raksa Wardaya Tanujaya, is it necessary someone getting bacterial vaccination in this pandemic COVID?
Yeah, it's very important, and I'm glad the question was raised, because the pneumococcal vaccination, which is what is being alluded to, I think, there's been a recent strong support and a call for the uptake of not only pneumococcal vaccine but influenza vaccination as well, in areas especially with high endemicity for COVID-19. It is actually a statement made out to all parts of the world. It depends on your background and so on. If you have got ongoing cases of transmission and high risk transmission still ongoing in many parts of Indonesia, for example, then it is all the more important for two reasons: not only to mask the background noise of other respiratory pneumonias and symptoms like fever and cough, but also to reduce the mortality associated. Because some of the COVID patients can have both things. They can also have a bacterial pneumonia. Streptococcus pneumonia is the most common. So please encourage the patients to get the vaccination.
Dr. Asok, I want to ask whether the influenza vaccine is can reduce the mortality with the severity if we get infected by the COVID-19?
No, it hasn't been shown in doing that yet. But well, sometimes all these infections get more than one pathogen involved. There can be co-infections. So, usually somebody who has COVID might also end up having a bacterial infection. And so you want to cover that as much as possible. Sometimes they might also have another viral infection like influenza on top of that. So for those individuals specifically, then of course you try to prevent them getting influenza in the first place. But if you ask me, there is no specific data that showed that by giving, specifically just influenza vaccination is going to reduce mortality in COVID per se.
Because in Brazil, that the data shown that the infected, the vaccinated with the people with vaccinated influenza, it's less severity compared to not vaccinated.
That's for general. So when they look at that, because when you look at population-based studies, when you look at vaccinations, then it can reduce the mortality overall in sick people. I think that you're looking at a big group, but for the maybe subset that it doesn't quite improve mortality in COVID-19 per se, it's not a therapeutic intervention. But generally speaking, of course, you have a lot of transmission going on in Brazil right now. So if you look at the use of prevention in terms of vaccination for pneumonia, for influenza, it is sure to help because you have so many thousands of people who are being affected. So surely you can help out by, but it's a general outcome, not a specific outcome to COVID-19.
So there is no cross-reactivity between the influenza vaccine with others with the coronavirus?
No, not that we are aware of.
No, not even the innate immunity?
No.
Okay, thank you.
Not that we know of, yeah.
Thank you.
Yeah, you're welcome.
Okay, I think we finished the discussion. Dr. Asok,
okay,
is there any closing statement? Is there any closing statement for this webinar?
Well, I mean, I again thank you for the opportunity to talk to all of you. And I think that as we engage any new product, I think it is also important not to use it wrongly. So every drug has to be discussed and the utility must be proper. And we don't want to go the way of one drug. It's always used, and then carbapenems, for example, everybody keeps using carbapenems, and now you have carbapenem resistance. So in the same way, every drug that comes, we have to know judiciously how to use it properly, which kinds of patients are going to, get the most benefit. And we must study our local antibiogram. We must know our resistance patterns, and we must know prescribing habits. So in other words, every institution, big or small, must have an antibiotic stewardship program.
Yeah. Thank you, Dr. Asok.
Thank you very much.
Yeah.
Thank you.
Ya, terima kasih atas perhatian peserta sekalian. Sebagai closing notes dari saya adalah bahwa mortalitas pneumonia pada pasien critical ill sangat tinggi, sehingga dibutuhkan antibiotik yang tepat. Mengingat meningkatnya sasaran antibiotik dan terjadinya resistensi antibiotik yang yang menimbulkan banyak sekali tidak banyak pilihan untuk dokter-dokter untuk memakai antibiotik, maka perlulah obat-obat yang sangat mudah didapat untuk mengatasi pasien-pasien dengan MDRO atau resisten terhadap antibiotik seperti ESBL atau dengan Pseudomonas aeruginosa resisten. Maka pada sore hari ini kita tahu bahwa ada opsi pengobatan baru seperti ceftazolozan tazobactam yang sudah tersedia di Indonesia untuk indikasi acquired hospital acquired pneumonia dan ventilator acquired pneumonia dan juga infeksi saluran